Hi, everyone. My name is Juliette. I'm a surgical oncologist at the University of Toronto in Canada, and I specialize in neuroendocrine tumors. So I'd like to thank everybody for the opportunity to present today on one of my favorite topics, which is access to care for patients with neuroendocrine tumor, which has been the focus of a lot of my research over the past few years. So the main disclosure I have with regards to this topic is that really when we talk about best outcomes, those are really patient dependent. So I'm going to present some things that, as clinicians and in discussions with patients, we've identified as important, but there's as many important outcomes and best outcomes as there are patients diagnosed with neuroendocrine tumors. Just keep that in mind as we go through the content of this talk. The main thing I wanted to talk about to start is about how we get care to patients. And, we like to think that in our modern and contemporary healthcare systems that we have the ability to treat a lot of people. And that's probably the case in Canada and in the US. But when we look at things very closely, our healthcare systems may not be performing as well as we wish they did. Indeed, this is the ranking from the Commonwealth Fund analysis. And we see that both Canada and the United States are not performing really well when looking at access and equity of care for patients. So what does that mean? Like, what is access to care and why is it important? Well, I think a lot of this was illustrated well in this seminal publication from the early 2000s that basically looked at care for a variety of acute and chronic conditions and simple things such as if you have a heart disease, do you have aspirin in your medication? Or if you have diabetes, do you get some special levels of blood sugar for monitoring? And what they found is that there was only 50% adherence to recommended care for things as simple as that. And I think that what that shows is that there's really a huge gap here that we are dealing with. So we know what is a standard of care, we know what will benefit patient, but only 50% are receiving it. So if we were to increase that to closer to 100%, we really have the ability to make a huge difference here. And that can make a much more of a difference than finding new, fancy, even very effective drugs or treatments. And that's what was coined the break-even point. And that was described as the fact that as a society, we tend to invest billions of dollars in developing new drugs and technologies, but really we're not investing much in what is called the fidelity of healthcare, which is making sure that those new drugs and technologies get to people who need them so that they are effective. If we have great treatments, but no one is able to access them, they're not going to be helping anybody. And so that's a huge gap here that we need to manage. And I'll try to see what are the few things that relate to neuroendocrine tumors from that aspect. So just to give you an idea of what this means concretely, if we look back at the COVID-19 pandemic, I remember sitting on a panel just before the pandemic started in March of 2020, and people were talking about what's going to get us out of this COVID thing. And basic scientists said it's going to be basic science. It's going to be finding a vaccine. It's going to be made in a lab, and that's what is going to save us from COVID-19. But that's not enough. We had the vaccine that was a magnific feat of science. But at the end of the day, what mattered is getting sure those vaccines were getting into arms. If they stay on the shelves, they're not going to help anybody. And that's what access to care is. How does that work for neuroendocrine tumors? So we know, and by I say we, you in the audience, know this better than anyone else. It's tough to get to a neuroendocrine tumor diagnosis. Now, I'm going to say one of the things I hate to say in talks is that this is a very busy slide, but I made it busy on purpose because I think it represents the number of people that see a lot of neuroendocrine tumors. So, see all the different type of specialties patients with neuroendocrine tumors will see prior to a diagnosis, and a number of times they will see them. It's like astronomical. And especially for sort of basic specialties like internal medicine, gastroenterology, or even family medicine. At the end of the day, we know that in Ontario, before a neuroendocrine tumor diagnosis, people saw on average their family care physician 18 times over 2 years. So those are times where they're not getting to a diagnosis. And even though they have access to care, they may not have access to diagnosis. The same thing was observed also in the US, where they confirmed that there was a lot of misdiagnosis happening. And on average, from the first misdiagnosis, there's about 3.4 years until the diagnosis of neuroendocrine tumor is established. So that's a big gap, and that's a huge opportunity for improvement in neuroendocrine tumors. Then once people have diagnosis, what happens with them? Those are the patterns of care over about 15 years in Ontario, and it's probably similar all across North America. And what we see is that this doesn't fit with the way that we conceptualize and think about neuroendocrine tumors. So first off, you can see not that much primary tumor resection for gastrointestinal lesions, when really that plays a huge role. A lot of liver resections, mostly in patients with pancreas neuroendocrine tumor, which is where most experts would say we're kind of hesitating there. Whereas in gastrointestinal, we'd be much more inclined to operate, but this is only 13%. A lot of chemotherapy use for a disease where chemotherapy is reserved for a very small proportion of people. And finally, very few liver embolization, even though they can help a lot. So the patterns of care are not really attached to what we think should be the care patients receive. So that's another issue with access and care. And in line with that, that is the one that's closest to my heart, I would say, is that we know in Ontario there were 60% of people that never saw a surgeon within 2 years of their diagnosis. And that's in a disease where surgery can help with people who have spread or metastases, or people who have only localized diseases still confined to the one organ. So again, 60% of people that don't have an opportunity to get the care that they might need. And so really, this is a sad statement, but like with a lot of diseases, receiving care for patients with neuroendocrine tumor is dependent on who you are, where you're from, and which hospital or doctor you get to. I won't give details like that, but there's a lot of data out there showcasing that there's a lot of vulnerable population not receiving care. And so how do we try to address this? So the first thing I think is to seek physicians or teams that understand neuroendocrine tumors. And I know a lot of the speakers will talk about this, so I'll go over it very quickly. But when we go into a neuroendocrine tumor clinic, we want to have our neuroendocrine thinking cap on. Forget everything else we know about different types of cancers and really focus on the specificities of neuroendocrine tumor, which really are a chronic cancer. And we're going to be treating for years to come with you. And so that means that the goals of therapy, the way we sequence therapy, the way we talk about it is very, very different. You know, when we think about this, that can be quite confusing for all of you and for patients. And that's where multidisciplinary care and specialized care plays an important role. So before I even started in my job in Toronto in our specialized clinic, so my colleagues interviewed patients and asked them about their experience with getting a diagnosis for a neuroendocrine tumor. And I mean, I'm sure I'm not surprising anybody here by saying that what was reported is difficulty with diagnosis, difficulty with information on neuroendocrine from physicians, difficulty finding treatment centers that had no knowledge in neuroendocrine tumors, difficulty in finding disease-specific support. And overall, that all summed up to a lack of a clear pathway for patients, both in diagnosis and also in accessing treatment afterwards. So what we built in our center was a specialized multidisciplinary clinic to sort of fix this and try to provide specialized care and support so that you're not alone on that path, and that path might be a little bit clearer. What does that look like? It's ensuring that we have medical, surgical, radiation oncology, and endocrinology assessing all patients, at least at the initial consultation, and then at each critical point of care, all in collaboration with the patients, of course, and our multidisciplinary case conference where we have other physicians caring for neuroendocrine tumors. And so this is the team that we work with, and I think that this is the crucial part of making sure people access treatment. Because as a surgeon, I don't know what I don't know. That's the first important thing. And I need my medical oncology, rad onc, and endocrinology colleague to tell me about things I may not think about that a patient might benefit from. And so having those teams is really crucial. And I think that's something that you'll hear a lot about during this education day. And we know from science that when people are treated by multidisciplinary clinics in cancer, it can improve the time to initiating therapy, the survival, because people get better therapy, stay on therapy longer, and get the appropriate therapy more often. And it also improves patient satisfaction. The problem with this is specialized care may not be easy to access. We know it's beneficial in this case because it's an uncommon tumor we're treating, very heterogeneous disease. There's as many neuroendocrine tumors as there are stripes on a zebra, as you all know. And so we can have a real impact there. However, we're often away from most people's home. We're in big urban centers, in tertiary care centers. It costs a lot for patients to get to us, taking time off work, traveling, etc. Not very convenient. And then the other reality is we have limited capacity. We're not able to care for everybody in those centers. So we also need to ensure there's some level of proximity care. And a lot of people think that those two concepts are completely opposite. Well, I don't think so. There's ways to provide proximity care while providing specialized care. And we're trying to implement right now some shared care models whereby people can see the specialized team initially to establish a treatment plan, and then subsequently you might have follow-up and enactment of those plans with their care teams closer to home, always in collaboration with the team in the specialized center. And when there's issues or concerns or changes in the type of the tumor, then we can see you again, or your doctor is closer to home, your oncologist can get in touch with the team so that it's a collaborative work. And then the last thing I want to talk about is in doing all this, we have to make sure that the care remains patient-centered, because accessing care is important. Accessing care that is tailored to you is even more important. So how do we do that? There's 3 things I wanted to mention that are important: supportive care, shared decision-making, and then education. I don't have answers for all those things, but I just wanted to introduce the concepts. So first off, again, I'm not teaching anything to anyone here saying that patients with neuroendocrine tumor have a high burden of symptoms. But I think it's important to know that that's reported by thousands of patients like you. There's a high burden of symptoms, and as you see here, those are moderate to severe symptoms reported by patients in clinic in Ontario. And the burden is high, but most importantly, this is over 5 years, and you see the nice plateau there. It means that there's something we're not doing right to make those symptoms better. And those symptoms are important. Most recently, what we found is that if people report moderate to severe symptoms, the chances of going to the emergency department or need an emergency hospital admission goes up 2-fold for moderate symptoms and 3-fold for severe symptoms. This means we missed something, and we missed an opportunity to intervene. And also that we can use those patient-reported outcomes that you fill out when you come to cancer centers to flag people in need of intervention and support so we can avoid needing urgent care that way. So that's a work in progress. Now, what does supportive care include? I can give an hour talk on each of those topics, but in general, think about psychosocial support, nutrition, symptoms control, and then financial support to address financial toxicity of cancer care. And that's why I showed you the team of clinicians we have. This is the rest of our team for supportive care that works with us on a daily basis to help our patients, and they are crucial to this. This is a quote that, as a physician, resonated with me, so I have to imagine that it does too as a patient, from Lynn Gates, who's one of the neuroendocrine tumor patients in Canada. And she said that in one of our education webinars, that palliative care is mostly about living. And the reason I put the quote there is because a lot of people, when they hear supportive care or palliative care, get scared and think it's about end of life treatment, and it is not. It's as much of a part of your treatment as would be getting therapy or getting surgery. And so the last thing I wanted to touch upon is shared decision making. Like in doing all of this, the decisions cannot be made only by the care team, but patients have an important role to play. And that's an important concept in cancer care these days. But surprisingly, we found that that may not be what everybody wants. So this is data from Leslie Moody from her PhD thesis at the University of Toronto. And she looked at scales of shared decision-making for neuroendocrine tumor patients. So in red here is the patient answers, and in purple, the patient advisor's answers. But interestingly, you can see that the majority of people preferred to adopt some level of a passive role in their shared decision-making, or shared leaning passive, meaning they wanted to put more of that decision-making on the physicians and get the recommendations. And that was modulated, and you won't be surprised with this again, by trust in their physicians. So the people who had moderate to high trust in physicians were more likely to say they wanted to assume a more passive role in the decision-making. So that goes hand in hand. And how do we make that happen? How do we create a care environment that ensures that you have access to care where you can participate in the role that you wish to take? And the answer to that right now is really, I don't know, but we're trying to figure out the answers. So we are interviewing patients in Canada, the United States, and Australia, asking what are the processes and structures of care that we can implement so that you feel comfortable taking the role you want to take and participate in the decisions that regard your care. And in doing so, education is key. And again, not teaching anything to anyone who decided to attend this day, but just highlighting that. And highlighting one thing that is important is that the quality of information you find online is not always the best. My team looked at this recently. We looked at the most common websites retrieved via Google and Yahoo. And what we found is that the validated scores were not very high. In particular, a lot of websites lacked information about what happens to you if you decide for observation or best supportive care, and what happens on your quality of life with different types of treatment. And so one thing I would encourage you to look for when you look for information online is this like health on the internet seal, which is sort of more of a guarantee of complete and comprehensive, accurate information, but sadly is often lacking. So I talked about a lot of things, some good, some less good, and I didn't want to like paint a bleak picture of the care for neuroendocrine tumors. Really what I was hoping to do is to empower each and every single one of you, whether patient, care provider, or other, to be advocates for your own health, and for your own care, as well as helping others get access to care. And there's many ways that we're able to do that. In summary, to me, good care and achieving best outcomes starts with an opportunity for care. So not everybody will decide to have treatment, but they should all have an opportunity to discuss it and be assessed for it. And so that implies having access to diagnosis and assessments, education and awareness of clinicians in primary care, access to multidisciplinary team and care that is tailored to patients, and then the use of shared care models and supportive care longitudinally so that we can provide ongoing support and achieve best outcomes. And so with this, I'll thank you and leave you on this beautiful photo of the CN Tower in Toronto donning black and white stripes for neuroendocrine tumor days a few years ago. Thank you.